I'm going to talk to you today about COVID-19 endgames. In particular, I'm going to talk about 6 major unknowns related to the virus and 4 strategies that we can use for getting back to normal and how they relate to those unknowns. My name is Spencer Greenberg. Today is April 27th. So first, some quick caveats. I'm not a doctor, epidemiologist, or government official. My background is as a mathematician and an entrepreneur. And I also want you to remember this is just one person's analysis of the situation. If you'd like to learn more about me, you can do so at my website, spencergreenberg.com. So there are 4 basic strategies that we can use against COVID-19 as I see it. The first, I'll call lockdown. The second, I'll refer to as control. The third, cocoon. And the fourth, open. Okay, so how do we get life back to normal? Well, unfortunately, doing so is going to depend on these major unknowns related to the virus. So let's talk about what those unknowns are. I've identified 6 big unknowns. There's some others that you might consider as well. But the 6 I've identified are 1, the infection fatality rate, 2, control openness, 3, the vaccine or treatment time, 4, immunity time, 5, existing prevalence, and 6, complication rate. So I'm going to go through each of those briefly. So the infection fatality rate is what % of people who get COVID-19 die from it. And now, of course, this is going to vary on the population, but we could ask a question like, okay, in the United States, what is the infection fatality rate if we assume that everyone is equally likely to get infected? Now, estimates for this currently are in the range of 0.3% up to about 1.3% for the infection fatality rate. And unfortunately, we're seeing lots of really misleading, wrong calculations that are being done online and shared in videos and articles. For example, people will look at the total number of people that have ever tested positive for the disease and divide by the total number of tests that were done, and then use that to calculate the infection fatality rate. But that is extremely misleading because the people who are tested are the people who are most likely to have the disease so far. Now, one thing that's really important to note is that already about 0.14% of people in New York City have died from COVID-19, of all the people in New York City. So that's over 12,000 deaths out of about 8.4 million people. And this might even be an underestimate because of so-called excess mortality, which is, if you look at how many people have died recently, it's actually substantially more people who are dying from things that are not being labeled as COVID-19 than you'd expect from normal. And so some of these deaths might actually be attributable to COVID-19, but we haven't properly attributed them. And this 0.14% number pretty much puts a lower bound on the infection fatality rate. Okay, this brings us to the second big unknown, which is control openness, which means how much can we open society in terms of both getting economic activity back to normal and in terms of not restricting people's freedoms, while preventing the virus from accelerating exponentially in the population. So if we don't get control openness right, the virus expands exponentially throughout the population, and we need to know how much opening of society can we do. Now, other countries are, of course, going to serve as a model for this because a number of countries have started opening in various ways. So, for example, we can look at Beijing and see what's happening there. The third major unknown is what I'll call the vaccine or treatment time. And this is how long it will take to get a vaccine, and also relates to the question of whether we ever will have a vaccine that works, because that is still an open question. We can't be absolutely sure we can make a vaccine. It also is about how long it will take to get an effective treatment that, for example, brings the death rate down by a factor of, let's say, 5. So some people are estimating right now it'll be 12 to 24 months for a vaccine, but we really don't know at this point. Then there's the question of immunity time, which is how long you're immune after you've been infected. It seems it's almost certainly the case that for at least a few weeks, you're going to be immune, and you're probably going to be immune for a few months. But the real big open question is, are you immune for years after you're infected or not? If not, that presents a big problem because you could actually become reinfected. The fifth big unknown is existing prevalence. So what percentage of people have been infected previously in different areas? And of course, it's going to vary a lot from region to region, and it's going to change quickly as the virus spreads. the positive cases, it's worth noting, are much lower than the number who have been infected. So for example, if in an area they say, oh, we have 10,000 confirmed cases of COVID, it doesn't mean just 10,000 people have been infected. There may be 10 or even 50 times more people that have been infected, because it's really limited by the testing capacity and whether they can find everyone who needs testing, and so on. Finally, the sixth big unknown is the complication rate. So what percentage of people who survive a COVID-19 infection end up with serious long-term health effects? Now, this might depend on the severity of the infection as well. And we've seen already many different impacts on the body from those who've had COVID-19, but the frequency of the different impacts and how long they stay with the body, how long you might have chronic conditions for that are caused by the virus, are still unknown. Now, there are some important things that we want to do regardless of what long-term strategy we end up using. So I just want to quickly point out these things that we should do no matter what. One, we want to keep the rate of the virus low enough to prevent hospital overwhelm. Because currently we think that if people end up going to hospital when they need it, rather than not being able to go to the hospital because the hospital is overwhelmed, they're going to die at a lower rate. And so as long as we think that it really does help people to go to the hospital, we really don't want the hospitals to get overwhelmed. That being said, I think there is still some uncertainty of the differential of someone's chance of dying if they went to the hospital versus didn't go to the hospital with different severities of disease. The second thing we're going to want to do no matter what is increase the production and distribution of medical supplies. Right now, unfortunately, in some areas, hospitals still don't have all the supplies that they need. Third, we want to develop and test treatment options such as antivirals as fast as we can, and we want to test them in a robust way. Fourth, we want to attempt to develop a vaccine no matter what. Fifth, we want to increase our testing capacity because many people who seem like they could have the virus are not currently able to get tested in many different areas still. And fourth, we want to increase contract tracing abilities, where we basically, when someone is infected, we want to make sure to be able to track down all the people that have recently seen that person and make sure those people get tested or isolated to protect them from potentially spreading the virus to others. Right now, the fundamental challenge we face is controlling R, which stands for the effective reproduction number. Now, the way to think about R is that for one person that is infected, how many people, while they have the virus, are they going to infect on average? So this is an example where R equals 2, where each infected person on average infects 2 other people before they're better. Now, R is affected by a lot of different factors. It's affected by how inherently infectious the disease is, by the behaviors of individuals, such as whether people choose to stay at home or go out a lot. It's affected by immunity, for example, which you might have because you were already infected. It's also, fourth, can be affected by early detection and quarantining or treatment of those people who get the virus. And finally, it can be affected by the environment. So things like temperature, humidity, sunlight may have some impact on R. Now, this is not to be confused with R naught, which is the basic reproduction number. So they're related to each other, but the difference is the basic reproduction number assumes that there's no immunity in the population, and it assumes no behavior change or government action. So the R reflects what's happening right now, whereas the R naught reflects sort of a theoretical that will happen under certain conditions. We think that the R naught for COVID-19 is probably between 2 and 4.5, with I think most estimates being more on the around 2.5 side rather than 4.5, but there is still quite a bit of uncertainty around this. Okay, so let's think about what happens when R is greater than 1. That means that each person who is infected infects on average more than one person, and that actually causes the virus to grow exponentially. So the number of people infected will just explode out of control. And this is what was happening originally when the virus was first seeded in the United States. We saw this exponential growth. Now, if R is approximately 1, the number of people infected each month doesn't stay perfectly consistent, kind of wobbles around, but it's generally going to neither be growing exponentially nor shrinking exponentially, but rather in a sort of steady state. Finally, if R is less than 1, and that means that each person who's infected infects fewer than one person on average, the virus will start to decay in the population, get reduced in size. Okay, so this takes us to the first strategy that we can use. And this is the strategy that I refer to as lockdown. And this is where we are right now, at least on April 27th in New York City. And it involves strict controls on behavior, like stay-at-home orders. The focus is on minimizing the spread of the virus, but many businesses close, extreme economic damage, and freedom is greatly restricted. And what's good about this is it gets R below 1, hopefully well below 1, and so it reduces the number of people infected each month. It also helps prevent hospital overwhelm and eventually may get the number of total active infections down to a much smaller level. What's bad about it is it destroys the economy, it greatly restricts freedom, it prevents many people from earning a living, and it's really not feasible to stay in this state long term because so many people are unable to work or do things they want to do. Now, fortunately, the lockdown seems to be working. So one set of data that's really, really cool is this data from the smart thermometers, where all these different people are taking their temperature throughout the country. And you can see here the number of observed influenza-like illnesses versus the number that's expected. And actually, the number observed is now, it started to rise above the amount expected, most likely due to COVID, and then it fell dramatically as people have been keeping themselves isolated. Another thing we can see is the number of Google searches for phrases like I have a fever, I have a cough, I have a sore throat, I have shortness of breath. And we can see that they spiked way up and now they've come way back down, getting down somewhere closer to the original levels that they were back in January. We can also see the number of deaths in the United States. And looking at deaths in many ways is more reliable than looking at total infections, positive cases, because the total number of positive cases hinges very much on our ability to test and how much capacity for testing we have, whereas deaths doesn't. And so this is actually a logarithmic scale showing the number of deaths. So a straight line on this would mean an exponential growing number of deaths. And you can see the orange line, which is the number of deaths, is tilted away from straight line and it's kind of been coming down, which is a really good sign. Okay, so which strategy should we use from here of the four? Lockdown, control, cocoon, or staying open? And as I mentioned, it's going to actually depend on these 6 unknowns that we started talking about. And I'm going to go through this and talk about the way each of these strategies evolves and the way that they depend on these 6 unknowns. Okay, so strategy 2 is what I refer to as control. And the goal here is open society and the economy as much as we can while keeping R less than or equal to 1. If we mess up, if we let R get too high, then we get this exponential explosion of the virus throughout the population, and we actually have to go back down to lockdown to get it back down quickly again before things get overwhelmed. Okay, so how do we succeed with this strategy of getting R less than or equal to 1? Well, we need to crush the infection level to a lower level initially, probably through the lockdown strategy. So it's very, if you haven't already used lockdown to get a smaller number of infections, or if you haven't started with a smaller number of infections, it's going to be tough to keep the R small enough. Then we could use a very gradual reopening, making sure to never let the R get over 1. And that means we have to be able to track the R very, very carefully to make sure we don't blow right past R equals 1. We also need huge COVID-19 testing capacity, and perhaps use things like fever testing or frequent, which is used in areas of China, for example, or maybe even daily symptom checks where you have an app when you go in and do you have any symptoms today, and you put in the app, that kind of thing, so that we can very rapidly detect when someone has the virus. We also need behavior changes, things like different levels of social distancing that are going to be tweaked over time, and perhaps things like masks in public. We also need rapid tracing of those in contact that have been infected, ideally using better technology. So as soon as someone who is known to have been infected, all their people they've been near recently can be contacted right away, and appropriate measures can be taken. Finally, we need to keep improving rapid care and quarantine of those infected. So we know someone's infected, we have to do the right thing with them to help prevent them from getting anyone else infected and help make sure they get the right treatment. Okay, the problem with the control strategy, fundamentally, is that it's not life back to normal. It's life back to normal insofar as we can keep R less than or equal to 1, but the problem is we don't really know how open we can make things and keep R less than or equal to 1. So we can kind of gradually relax this strictness of the control as we get better and better strategies for keeping R less than or equal to 1. But we may still be doing significant damage to the economy, we may still be significantly limiting people's freedom, and the better we get the control strategy, the more we can open up, the less we do those things. And so one longer term option that is presented to us is to try to do as good a job with control as we can, where we open things up as much as we can, but basically stay in the state for quite a long time until either we have a vaccine or we have substantially better treatment options than we do today, so that the infection fatality rate is much lower. Now, one little caveat here is if the R varies a lot in different subpopulations, then we may need to do more than just keep the R less than or equal to 1 on average. We may also have to actually make sure it doesn't vary too much in different subpopulations. Because if let's say on average R is slightly less than 1, but in small subpopulation R is at 3, then very quickly that subpopulation is just going to explode and may soon overwhelm and kind of defeat the purpose and blow right past R equals 1 for the whole population. So keeping the variability low may also be essential. Okay, so is control a good long-term strategy or not? Well, it's going to come back to these 6 unknowns. And in particular, in this case, focusing on just 2 of the unknowns. The second one being control openness. So if we can open society a lot in terms of economic openness and freedom, while keeping R less than or equal to 1, then staying for a long time in control strategy is a lot less painful because we'll have much more back to normal. But also, it's going to hinge a lot on number 3, which is the vaccine and treatment time. So the shorter time to vaccine or to an effective treatment means that waiting it out in the control strategy is going to be much more viable and more likely to be worth it. Whereas if it took a really, really long time to get a vaccine or good treatment, the appeal of being in this sort of semi-lockdown state where we're sort of open but we're sort of not for potential years, that's potentially not very appealing. And ideally, we'd consider doing something else if we could. Okay, this takes us to strategy 3, which is the cocoon strategy. And here the goal is to open society to all low-risk people as fast as we can without overwhelming hospitals while keeping elderly people and high-risk people cocooned in safety. So basically the idea is you assume with the cocoon strategy, the young healthy people will get infected, but then you try to protect people who are at high risk. Now this is based on the idea that young healthy people are actually at far less risk. And you can see here, these are some early numbers, I think these are from China, where the risk that the virus posed to people in terms of fatality was dramatically higher in older people than in young people. And so if that's true, the having young people get infected will lead to far, far less deaths. And I've actually seen some really mistaken calculations claiming that herd immunity can't possibly work, but those calculations didn't take into account the fact that the young healthy people getting infected actually have potentially way less likelihood of dying or even getting extremely sick than older people. Now, the basic principle that this relies on is this idea of herd immunity, that once more and more people in the population are already infected, if they have immunity to getting the virus again, then that means that each person has fewer people that they're able to infect because some people are immune, and this actually can cause a total infection of the population not to go to 100% as what you think if things are growing exponentially, but rather to kind of top out at a level maybe something like 40 to 80% of people infected. And you could just do kind of a naive calculation to estimate this. The herd immunity threshold is 1 minus 1 over R naught, but that's really a very rough approximation, and in practice, this would have to be done very carefully, and we have to make sure to try to get it to top out at the lowest level possible. But intuitively, it does depend on the R naught reproduction number. So. All right, so now this leads to the question is cocoon a good long-term strategy? And again, it's going to hinge on a bunch of these unknowns. For example, the infection fatality rate, the lower this is, it makes cocooning more appealing because it makes it less dangerous to have young healthy people get infected. And it's going to especially depend on specifically on the fatality rate in young people and healthy people as well, not just the average infection fatality rate. It also is going to depend on number 3, the vaccine or treatment time. So the longer time to a vaccine or an effective treatment makes cocooning more appealing, because if it's going to take years to get a vaccine or we're never going to get one, well, then cocooning might be a good strategy potentially. It also will depend on the immunity time because this is a totally useless strategy if prior infection doesn't grant long-term immunity, because then the young people will go out, get infected, but you don't get herd immunity, and so it doesn't actually protect the high-risk people later. It's also going to depend on number 5, the existing prevalence. So if more people in the population are already infected, getting to herd immunity is less costly. For example, if you already have 20% of people infected, then you don't need to go that much further. Maybe we need to go to 60 to 80% to get herd immunity, but that's less costly than if you start at 2% of people already infected. Finally, it's going to depend on 6, the complication rate. So this strategy is also going to be unappealing if a large number of people who are infected end up with long-term health complications, even if they survive, because in that case you could be putting lots of young people at risk for long-term health complications. There's one other caveat with the cocoon strategy I just want to mention, which actually it hinges on our ability to keep high-risk people safe, which might be a lot easier said than done. So it's actually been a challenge so far with there being many infections occurring in elderly homes, despite people's attempts to keep them safe. And then we also have to keep taking into account the fact that plenty of high-risk people live with low-risk people. And so if you have high-risk and low-risk people living together, you have to kind of treat them as a unit, and you have to keep that whole unit safe. Otherwise, the low-risk person can expose the high-risk person to the risk. Okay, this is just strategy number 4, which is the open strategy. And here the goal is open up all society as fast as we can without letting hospitals get overwhelmed, and assume that just 40 to 80% of people will eventually get infected, and then we just deal with that. Okay, so is the open strategy a good long-term strategy? And it's going to depend on a bunch of things, specifically these unknowns. So it's going to depend on the infection fatality rate. So this is only really a viable strategy if the infection fatality rate is sufficiently low. If it was too high, then this would be an unacceptable loss of life. It's also going to depend on the vaccine or treatment time, because the longer the time is to a vaccine, or if a vaccine is not even possible, and the longer time to effective treatment, then this becomes more killing potentially. It will also depend on immunity time, because this is more dangerous if there's no immunity, in the sense that, okay, you just sort of let society get infected, you open things up, but then if the virus just keeps reinfecting people over and over and over again, that could just cause more and more fatalities with each wave of the virus. It also is going to depend on the existing prevalence. If again, like the cocoon strategy, if more people are already infected, opening up is less costly. And finally, it's going to depend on 6, the complication rate. So this strategy is also unappealing if many people are infected end up with long-term health complications from the virus. It's worth noting that these 6 big unknowns and our information about them are going to shift over time. So we can't just measure these things once. We have to keep working on measuring them. For example, the infection fatality rate could actually change a lot with mutations of the virus. Some people say it's already mutated and changes fatality rate. But we have to track this really carefully to see if they're different strains and how dangerous each of them is. Antivirals and other treatments are also going to potentially, if they work, bring down the infection fatality rate a lot. And so that we have to monitor that very carefully as well. In terms of control openness, we may develop better strategies over time for opening up society while keeping R less than 1. For example, more advanced tech solutions. Also, changes in the environment might change our ability to use control openness, because as the temperature changes, humidity, sunlight alters in different seasons, it's going to make it somewhat easier, somewhat harder to keep R less than 1. It may not have a dramatic effect, but it might affect it somewhat. Then there's the vaccine treatment time, which as time progresses, we're going to get more and more information about this as different vaccines are tested and go through different phases of trials. Then 4, there's the immunity time. So the more time that has elapsed since some people were infected, the more we can actually learn about the duration of immunity that grants you. Then there's 5, the existing prevalence. This is, of course, changing all the time as the virus continues spreading in the population. And also, if we attempt and fail at a control strategy, this could cause the prevalence to suddenly surge. Finally, there's the complication rate, and the more time has elapsed, the more we'll know about how long these long-term complications and health effects might last for people, and also how often they occur. So ultimately, to pick the best strategy, we must increase our clarity on the big unknowns. But unfortunately, right now, we have lots of low-quality evidence, even though what we need is high-quality evidence. So we have many studies where people are rushing to do whatever study they can do, given the emergency situation and the opportunities in front of them and the funding they happen to have. And it's through no fault of their own, because of the craziness of the situation. A lot of those studies, unfortunately, are just giving us really low-quality evidence. What we really need is some really well-designed, high-quality studies that really allow us to measure these parameters to make good decisions. And so just to get some ideas of how this could be done, so the infection fatality rate, well, if we were going to really accurately track all infections and the outcomes in the entirety of some age-diverse population where nearly everyone has been exposed, this could enable us to actually get a much more accurate measurement of the infection fatality rate. And unfortunately, most existing studies have had really severe problems. Like they've had really high false negative rates on the test being used, or they're only testing for active infection, or they're not doing careful follow-up with everyone in the population. So it's really hard to measure. Then for control openness, we can't do carefully controlled studies on this, but we can learn from other regions. We can look at what different states are doing, we can look at what different countries are doing, and we can learn about what worked for them and what failed for them. And we can also do our own experiments where we gradually adjust something and see if the R changes significantly, and we kind of keep relaxing things in these kind of careful experiments of our own. Then when it comes to vaccine and treatment time, all we can really do there is closely monitor the progress of vaccine studies to get more or less confidence in the vaccine coming soon or coming distantly in the future. Another thing that could happen with vaccine studies, though, is if there were people willing to volunteer to get an early stage vaccine, knowing that it might not work, and then actually potentially even volunteer to being part of a challenge trial, that could actually give us information faster. Of course, we have to do that very carefully, taking into account ethical considerations there. Okay, what about immunity time? Well, in terms of immunity time, if we were to do periodic, accurate retesting of a group of people who've been previously infected, so take a bunch of people who've been infected with the virus, and we know they're infected, every single month, again, measure whether they've been reinfected, or even if they're willing to volunteer and be done ethically, doing challenge trials where people who previously been infected agree to actually get reinfected under certain scenarios. This could actually give us a lot more information on immunity time, which is a key parameter. Then in terms of existing prevalence, ideally we would be randomly sampling people in the population, perhaps by their home address, sending a mobile team out there to give them serological testing if they're willing to participate. And this could give us a much better idea of the existing prevalence. Unfortunately, most studies have had really severe problems in estimating prevalence because either they're not sampling the population at random, so we don't really have a random draw, so it doesn't actually give us an accurate estimate, or maybe the false positive rates of tests are too high, or the only test for active infection. So we really have not had very good data for the most part on this. And then finally, for the complication rate, if we had really careful long-term tracking of how well people are healing who've been previously infected, so if like 1,000 people are previously infected, we just track all of their symptoms and how those progress for months and months, that could give us a lot better information on this. So to summarize, we need higher quality studies. These are absolutely essential to fund. These are going to help us resolve the big 6 unknowns, and this knowledge will enable us to choose the right strategies to fight COVID-19 and to think about how do we use lockdown, how do we use control, how do we use cocoon, how do we use open, which combination of them do we want to use at which points to best beat this virus. But thank you for watching, and if you'd like to learn more about my work, you can check it out at spencergreenberg.com.